Andrew Van Lint from University of Adelaide here.
And Adelaide Boylan, also of the University of Adelaide.
So we're at the lovely Canberra airport, and thanks to Hudson's Coffee for unknowingly sponsoring this little discussion. We've just finished the ANZAHPE conference, and so we'll just have a bit of a chat about day three. Day three started with a symposium which was focused on simulation, in particular the concept of masthead. This is a thing where they are trained in a 2-day course on wearing particular masks and taking off certain characters, and that particular character or patient is often used for several years of a course or in multiple courses, and they have a particular past medical history and a way of interacting, personality, relationships, and using that mask and even other parts that can be added on to the whole set at varying cost. They found it's a really meaningful way to interact. Well, you work in Sim, Adelaide. What did you kind of take away from that one?
So I thought it provided some really amazing opportunities to think about how you could deliver education around chronic care and longitudinal care. So probably more my bent as a GP, and how we engage our medical students and other students into that process. It did cause me to reflect a little bit on how you could deliver it to such large cohort sizes. So they talked about the limitations of the mask, being you could really only wear them for about 15 minutes a day, and the cognitive load of being in character as well as educating could be challenging. So I think it would be difficult for us to extrapolate that to cohorts of 150, 200 students just because you couldn't wear the mask for as long as that.
I thought it was really cool that they even translated some of that character and the masthead stuff onto some of the procedural teaching to make that, not just technical on an obvious dummy, but they had a set of shorts effectively that simulated the groin and thighs of female anatomy that the person can wear, and it can actually be catheterized. And so to actually have someone in character with this masthead of being elderly lady, and then needing to have a catheter, and then discussing with the person doing the procedure, whilst I thought that was a very high level or authentic simulation. And they were saying that it was a really effective learning tool that was quite challenging and helped that translate to clinical practice for the students.
Yeah, I also thought they described in that setting is quite brave of the educators with their cohort to be willing to do that and expose parts of their own body as well as the parts wearing the mask, but also how immersed the students were for them to later write back or ring up and comment, I just realised that was actually you. I'm sorry, I was just so invested in the activity, which just went to the heart of amazing simulation. So it would be a great thing for us to engage in a bit more. So we've got the mask, so we should be trying to do it.
Yeah, cool.
Yeah.
After morning tea, I went to a session that was on burnout and how do we identify and how do we prevent burnout. So it was a bit of a workshop. The presenters, which were a mixture of ANU and I think either Auckland or Otago, I can't remember which one, but some of our Kiwi colleagues, presenting a few ideas, but then having a range of activities where we talked about how do we do particularly burnout for clinical educators and academics, but translating that into students as well. So it was nice to actually have that conversation. Some of the themes that we brought out about that was, how do we identify and prevent burnout within our colleagues as clinical educators, and I think the idea of early identification, about having a safe environment that can have conversations of, are you okay, or we know something big happened, how are you going now? Can there be more collaboration to help each other's workloads at times of difficulty and stress? Support and leadership from a higher level to identify and make sure that people's workloads and support is appropriate in individual seasons, and advocacy as well, because some people won't speak out of their own thing, but of their own challenges. But if they've got a colleague actually going to the director and saying, look, I'm really concerned my colleague is under unreasonable workload or is struggling and is just not comfortable with talking about it, can we help them together? They're good ways to go about it. There was also themes of how do we get students to talk about or put their hand up and say, oh, actually I need a bit of help because I'm getting close to burnout. So we talked about the idea of vulnerability, and that sometimes as staff members we need to exemplify that, both in terms of looking after our own well-being, but exemplifying some vulnerability. So I shared the idea that for myself with my third year students, I share the fact that I've failed third year. And so people that have encountered failure then suddenly feel more comfortable talking to me about that struggle, and about the idea that when you have really struggled, really been challenged, or actually got to the point of suffering, which a lot of our students don't know really what that's like, but many of them really do, or just are discovering it as they face particularly personal challenges, they feel way more comfortable putting their hand up because they go, this is a normal thing and I can talk about it. So that was really refreshing to hear that many of us do struggle, many of us do are aware of burnout or maybe have faced it in the past, and it's a really important area to continue the conversation.
After morning tea, I was at a session around interprofessional learning where people presented some really interesting and dynamic papers, some projects out of Tamworth around shadowing other students, and then the application of the knowledge learned through shadowing to patient care, so using physios and radiology students, just tracking the patient journey through the emergency department in an acute musculoskeletal injury. Was a really translatable model that they presented, and I think we could try and implement that into some of our practice. There was a great follow-up study presented around a cohort of students from 2012-2013 who had an immersion experience for 5 weeks in New Zealand, living in a house where there were students from multiple different disciplines. They followed them up at 5 years with an 80% response rate, which I thought was unbelievable.
Huge.
With no incentives, when I think standard expectation would be you might get 20 to 30%. So
if you responded, thank you.
Yeah, you've really contributed to the literature and also empowered some of us to think, could I be doing that? Can I follow up my students? Actually, it is possible. The technology's there. It's easier to follow people than it was 5 to 10 years ago.
Yeah.
So that was an awesome presentation, and some other really interesting things around IPL and student interactions, and also this follow-up and tracking and impact. How are we assessing the impact of our efforts around interprofessional learning? That's been a common theme today, and the subject of a debate this afternoon, which is really stimulating and thought-provoking, and a cause to reflect on the current culture and culture change.
Yeah, I also really enjoyed the debate, more than I expected I would actually, about people highlighting there's not a lot of, well, I should firstly say the debate was about, does interprofessional learning and education produce better patient outcomes? And there were some good points made that there is some evidence that it is helpful in development. There's probably not very good evidence that it does actually equate to patient outcomes. But we raised the point that a couple of really interesting points at the end as the presenters reflected even on their own discussions and debate. One of them said, does it have to equate to patient outcomes? What if it clearly doesn't equate to better staff outcomes? That should be good enough actually, because it could be that the patient outcomes are the same, but the way that we arrive at those outcomes is perhaps easier and more straightforward for staff and a more collaborative effort, and that's a good thing.
Linking back so nicely to the burnout discussion and how can we make work a more enjoyable place for people, a more manageable thing to do.
Yeah, and I really liked the last speaker's point that he said, well, let's say it doesn't have evidence, well, neither does teaching anatomy, so should we chuck that in the bin? What about teaching physiology? Very little evidence to say that improves outcomes. And then he finished with a slide that said, here's a point that was in a particular journal some years ago that pointed out that the parachute has no evidence that it saves lives, and yet we use it all the time. So I thought that was actually really refreshing to go, well, evidence, but what are we, what's the actual standard we're working from? And that, for me, that was some really refreshing perspectives.
What are the underlying assumptions that drive you to try and find evidence for things?
Yeah.
And what are we not seeking evidence about at all?
Yeah.
Really interesting. I think that was a great way to wrap up the conference.
Yeah. Absolutely. I had some really great, I went to some other sessions on feedback, a couple of them. One was a really great scoping kind of review. That's probably actually not the appropriate thing, but they looked and used some particular theories that showed that across their review of many papers on feedback, which was primarily in the workplace setting, is that there were some themes saying that if it needs to be relatable, so if you can connect or somehow relate to your supervisor or the person giving you feedback, the feedback is likely to be more effective and is more likely to be well received, and is more likely to promote productive discussion and dialogue. I can definitely relate that to my own experience. It also, I'm trying to think of the other two elements. They had like 3 kind of themes that went with that. Can't remember them right now, but that was really interesting because I'm thinking about, can I do more research into feedback, because I'm really passionate about that, and so I've emailed them, and they're gonna, that particular presenter who's obviously read a lot of papers, and I'm struggling to find the papers, so she's gonna send me some hot papers to look at. And for me, that's what I wanted to kind of finish on was I've really enjoyed the conversations and the networking side. There's a lot of people of varying. I love that. Like I really see myself as a very junior academic, a kind of, and maybe not so much junior educator, because I've been doing this for a few years now, but someone that's still in the early career side and my clinical side. And I'm having conversations with deans and directors of areas like we're equals. I feel really humbled that they'll just have a chat to me and ask me and go, oh, you're a registrar and you're doing teaching, that's fantastic. Tell me a bit more about what you're doing, and made some connections with some great consultants and educators and academics from across New Zealand and Australia, and it's cool. It's cool, and just hearing about what they're doing.
Equalising conference, and at the beginning they talked about the ANZAHPE family and welcoming new members, and I really feel that was a translatable point. I felt like it was a great opportunity to meet people who are like-minded and interested in doing great education.
So those are the thoughts. Thank you very much, Adelaide, for joining us.
Thanks, Andrew, for having me.
See you later. Thank you, Hudson's, and we're coming back, Adelaide. See you soon.